I'd like to thank everyone for joining us in this webinar today from all across the world. My name is Rizwan Sarwar. I work in Oxford, and I'm moderating this webinar with two esteemed echocardiography experts, Dr. Roberto Lange from Chicago and Professor Paul Leeson from Oxford. I would just like to ask them to introduce themselves briefly. So Roberto.
Yeah, thank you. First of all, thank you for the invitation. My name, as you said, is Roberto Lange. I'm the director of non-invasive cardiac imaging here at the University of Chicago, and I'm a professor of medicine here.
Thank you very much.
And I'll introduce myself. So I'm Paul Leeson. I'm a cardiologist here in Oxford and run the cardiovascular clinical research facility. And as a professor of cardiovascular medicine here, been doing echo for many years and seeing many patients with different conditions. I'm also pleased to be very proud to be one of the founders of Ultromics as well, which has gone strength from strength since it spun out of our research group.
Thank you very much. And so the topic of this webinar is the value of strain. And I suppose, first of all, starting off with this, I'd like to ask the two of you, Roberto, let's start off with Roberto. Can you tell me about a memorable clinical case where you found that measuring strain was useful in your clinical management, whether that was diagnosing or managing a patient?
Yeah, well, thank you. That's an interesting question. So I will briefly mention two situations. One that I find particularly useful is the fact that, both the European and the American societies have produced sort of very complex guidelines on how to assess diastolic function. And you have to go through these complex algorithms and you have to acquire a lot of data. So one of the things that I'm very excited about is of the use of left atrial strain as a single index to measure left atrial pressure or left ventricular end diastolic pressure. Now, from a point of view of a clinical experience, I the other day was studying a patient with cardiac amyloidosis, and I was sort of struck by the fact that this patient had preserved left ventricular ejection fraction, but the global longitudinal strain was low. So we went and measured it again, and we were sure about the findings. So we then, there must be something that is making this patient preserve the ejection fraction, despite the fact that we're talking about the ejection fraction that was, I think, 54, and the GLS was 12 or 13. So it was really, really low. And we actually have now some software that allows us to look at the circumferential strain. And we did that, and the circumferential strain was very high. So the preservation of ejection fraction was in this amyloid patient based on the fact that the circumferential strain was compensating for the longitudinal strain. And then we found another group. And so I think that by using all the different components of strain, there's a lot of physiology and clinical things that we can learn.
Absolutely. And the left ventricular strain is the bread and butter, and it's part of the evolution from ejection fraction to measuring systolic function. And certainly left atrial strain, it's starting to be used clinically, and it does have a clinical purpose. I don't use it routinely, I have to admit, in my clinical practice. Paul, can you tell us about a case that you were involved in, a memorable recent case, if possible?
Yeah, no, thanks, Riz. And many thanks for sort of prompting this question before the webinar to give some time to think about this as what would be an interesting case to share with the audience. And I was thinking about this. We hear about strain used in many situations which are quite useful, like amyloid and others. And I was trying to think of a contrast to that, which is also a very practical example. And it reminded me of a patient we saw a year or two ago who was a chap, or actually it was last year actually. He was a chap in his 40s, and he came to the clinic and basically was worried about his exercise capacity. So he'd previously been fit and well, had a busy active job in a sort of high profile profession, and he'd actually had an episode of COVID. And 6 months later, 9 months later, his exercise capacity just wasn't what he was expecting. And he came very worried about this, really concerned. His baseline investigations were pretty normal. He didn't have cardiovascular risk factors. And so we decided to, how you manage these patients, there's no strict guidelines around this. So we decided to do an exercise echo and get a feel for what might be going on with his myocardium. And we did a baseline echo. He had normal ejection fraction. We put him on an ergometer. He got several watts of power on that, got his heart rate up, and his ejection fraction improved and it increased. He felt pretty tired after doing the exercise, but his ejection fraction had improved. And we were left with this situation. So this is the chap who's got quite subtle but very noticeable change in exercise tolerance. And he's worried about this. And you exercise him and his ejection fraction increases. And it's kind of what you'd expect with a guy in this situation. So what do you do next? Are we, could you really say, you could say, well, that's fine, it seems to be all right, go away, that's okay. But we wanted to do something more for this patient. And so we decided to measure strain, basically. And we looked at strain at rest, and we looked at strain and at exercise. And actually what was really interesting, what was helpful, was that his strain was normal. So at exercise stress and at rest, his myocardial strain was normal. And that was really quite a key point where actually things changed in terms of what we could say for this patient, because we weren't just relying on an EF, which is can be a little bit variable, but tends to be going up with exercise. But we had an assessment of what was going on in the myocardium in terms of myocardial strain. And we know if you're developing problems or early declines in cardiac performance, then your strain starts to drop off. So, but his strain was entirely normal. And so we fed back this information. We told him that we'd use strain to look at this. We looked at the EF. And we said, well, on that basis, why don't you start doing a bit more exercise and sort of building back up? And I remember this patient because actually he came back a few months later and he said, brilliant, great. I had the reassurance of what I was seeing in terms of what you told me, got back to exercise, I'm feeling a lot better for it. So sometimes it's not necessarily the abnormal strain, which I can find useful. It's those situations where you have an EF and you would need more, you need another assessment of LV. And that's what we got in that case, and that proved very useful.
That's sort of a useful and a good example of a ruling in disease and also ruling out significant disease, and clearly both of them have led to changes in management and for the individual. So that's an interesting one. And in terms of strain, so in the wider cardiology community, really the first area that strain is used is cardio-oncology, particularly monitoring for subtle signs of cardiotoxicity from agents. And there's also been, in the recent AHA, ACC guidelines on chest pain, for both acute and non-acute chest pain, there's mention of strain in those guidelines. And actually we'll be having another webinar next month on the 9th of March covering the chest pain guidelines. And in terms of going back to strain, we're all very, very familiar with ejection fraction. And we've been monitoring ejection fraction with echocardiography for decades and previously by cineangiography. So bearing that in mind, is there really a need? And how has, in terms of the background to developing strain, why should we even expend the effort and time to test strain, Paul? If I can ask that question to you, Paul.
So I think that's a good question. So thinking about the history of strain, the strain has evolved from a sort of desire for a long time about wanting to know more about what's going on at a myocardial level. The predecessor to strain we had was things like tissue Doppler imaging to be able to look at myocardial motion. You could obviously sample small areas of the myocardium, look at motion. Still proved very useful for looking at diastolic function assessment. But you can only pick out single points. And obviously the development we've reached with strain is you can start to look at across the whole myocardium, and you can start to look at different areas of the myocardium all simultaneously from single images that you're acquiring. And so that certainly increases the power of what you can do at understanding myocardial function. And I think why I pose it a different way, which is if we're measuring a valve dysfunction, we don't just use one measurement of the size of a jet or something to decide how severe the mitral regurgitation is. We use 3 or 4 measurements to be confident that what we're seeing has a level of precision. And when we're looking at left ventricular function, at the moment we just rely on one EF measurement, which we've been doing since the dawn of echocardiography, where we used to do it with an M-mode slice to get a measurement of how it changes in diameter. It's been around a long time, but actually it's one single measure. And what the strain gives us is it gives a much more sophisticated look at how we're assessing left ventricular function. And I think and we haven't done it a lot because it's been quite difficult to do, I think, as you've commented on, that it's been quite difficult to get measurements. But it is becoming quite easy now to get left ventricular strain measurements. And in that situation, it's actually almost easier to get left ventricular strain measurements now than it is to get some of those valve measurements I've mentioned, or even the diastology measurements, following complex guidelines. So if you have that extra information about LV, we should be using that within our holistic approach of understanding what's going on with the left ventricle. Is my view.
Yeah, absolutely. And certainly when whether it's aortic stenosis or any other form of mitral regurgitation, we do take a number of measurements, both of the left ventricle, the valve, the left atrium, and we sort of integrate, and also the right heart as well. We integrate them into our assessment of the severity and also to direct patient management. And having talked about this, and you touched on ejection fraction, if I can just turn over to Roberto, and if I recall the chamber quantification recommendations that you co-authored on behalf of the ASE and EACVI, in those recommendations, there are some normal reference ranges for LV size, volumes, mass, and ejection fraction. So my question to you is there a recommended normal value from the societies, from the ASE and EACVI and other societies for strain, for GLS specifically?
So that's a good, very good question, and I know a little bit about this. So the first thing I would tell you is, the chamber quantification guidelines from both the European and the American Society was written in the year 2015. And by the way, that is the article that is most quoted of everything in echocardiography, not because it's so good, but because everybody who writes anything uses that to assume that if they quote it, what they're doing is correct, okay? But let me tell you, if you look carefully into those guidelines, you will see that the normal values were extracted from a relatively small number of patients, and all of these patients were white European or North American patients. No type of other ethnicities have been properly represented there. So that's the first thing. At that time, we did not have a lot of, at that time, we were talking a lot about the differences in strain that we had within the different types of equipment. So we could not come, if you look carefully, there is a table of normal values for each type of vendor. But we came up with a consensus that was probably not very far away of correct, of -20 as the normal values. Now, since then, the Europeans have done the NORRES study in a much larger group of patients, still predominantly white. ASC did a huge study, which I helped do, which is the WASTE study, that incorporates over 2,000 patients from 19 countries and different ethnicities. So I can tell you that the normal values will change. What I also know now for sure is that there are differences in strain between both sexes, with women having higher number than normals, and than men. And the other thing that happens is that there is an age dependency of strain numbers of the GLS. So I think in the next chamber quantitation guideline, which is now being prepared, we will see all of that. There will be changes in the normal values. They will be sex and age dependent, because that is sort of, and also ethnicity. People, let's say Asian people or people that have smaller end-diastolic volumes, like people in Asia, have different values of strain than people in Australia or Europe or the United States that have different. So there's a lot of work in that area, which I think is very interesting.
That's fascinating, and we will look forward to those guidelines coming out. But you mentioned the changes across age and ethnicity. Being, from a practical point of view, and in terms of interpreting an echo, and it gets, the more and more reference ranges, the more and more precise we go with echocardiography, the better it is for patients. But it takes longer to analyze and I should say, interpret the result of the abnormal strain, and that's sort of similar to a certain extent with tissue Doppler as well, which is well known to change with age too. And so that isn't that a practical consideration to bear in mind?
Well, but I don't know if I would 100% agree with what you said, because first of all, I mean, there are studies that now very nicely show that global longitudinal strain has less variability than when we do a biplane ejection fraction, right? So, and the other thing is that there are beautiful software. One of them is from your company, and there are others around there that calculate the global longitudinal strain using artificial intelligence, and it does a really, really good job, which will once again decrease the variability. So, I think that as we move ahead, and be interesting to see what Paul thinks about this, we will do an echo, and when it gets to the point that when I have to interpret it, all of these measurements will be done automatically, and I will probably only if I need to correct it, and many times it's better not to correct because you somehow make it worse when you correct it. But I think all of this will happen, and I see it in our lab. We use now GLS in every single study. In the United States, you get an extra payment for doing it, which is the largest motivator for people to do this. And so I don't know. I think it will take, I'm not sure that this will take a less amount of time. And all these normal values can be incorporated in the artificial intelligence. And according to a number, you will be able to color code it if it's an oncology patient that is 10% different, or if it is, whatever, or if it's normal, abnormal, whatever way. So I think all of this is really, really happening in echocardiography.
Yeah, maybe I can come in there. I'm really fascinated by the US approach in terms of providing a cost code for strain. I kind of wish we could have something similar in the NHS, because not because of the money generation, but because actually it gets people using strain. And I think that's one of the challenges of things we really need to get beyond, which is there is one of the disadvantages of strain a little bit at the moment is it has been around for a little while, and we've had different ways of trying to measure it, and people have got used to that, and we've kind of lost sight of the fact that actually strain has really moved forward in terms of accessibility, low variability. So actually as a measure, it's incredibly useful. So it is quite forward thinking in the US to say, actually, well, let's get people using this, and we'll pay them to use it because we see the value in this. And that's certainly not something we have in the NHS at this point, but it would be lovely if we could, because I think when you get people using strain, you begin to understand exactly where that fits into practice. And it sits alongside your EF or your other measurements. I wrote an editorial for Jack Cardiovascular Imaging a few weeks ago with one of my colleagues, Andy Fetcher, and we talked about this idea that actually what we need to do is just start reporting strain as a measurement and start working with it, because it's going to be there, it's available, and then you start seeing, actually, if you have a normal EF, like in my case example, if you have a normal EF and you have a normal strain, that gives you huge confidence about what you're looking at. Whereas actually, if you have a normal EF but the strain is a little bit different, then you can start to understand and start to explore a little bit what might be going on. I think having this ability to handle strain as one of those metrics which we can work with is going to be great as uptake increases.
Fascinating, and sort of, I think you're right about that. When I started off measuring strain, I remember the first case I did, I spent a long time contouring, and I sort of an adjustment here, an adjustment there, an adjustment there. And one of my colleagues who was actually sitting next to me and analysing another case, did the strain analysis very quickly. And I frankly found that a lot of the time I was spending probably wasn't needed. And there was a change in the value of strain that incorporated, that caused a significant level of variability. If I were to go back and do it again and made similar micro adjustments or didn't, that's one of the issues about strain, that variability. And Roberto, you mentioned how EF has a higher variability than strain, and has that's, to my understanding, has been shown across multiple platforms, multiple sites, in multiple diseases. Yet there's still a perception about variability in strain. Why do you think that perception still exists?
Because I don't know for sure, but as you're talking, I'm thinking, and I say, well, I think it probably has to do with the fact that, the strain methodology or technology probably has really evolved a lot in the last 2 years. Before we were talking about GLS, now everybody's doing left atrial strain and so on and so forth. And I think it mostly has, for a long time, people predominantly use just the GE platform to do it. And then Tomtec and Philips came and Ultromics. I think that very few people have truly experienced state-of-the-art software that does these measurements in an automated way. If you experience that, you can see that the variability would decrease quite a lot. So I personally would think, I don't know if I'm right, but probably the fact is that people have not experienced the use of artificial intelligence to get these type of measurements.
Sure. Thank you very much. And I remember when I was learning practicing strain on the early days, and it took some time to be able to learn to use the software. And in certain hospitals and clinics, they have a multiple different vendor platforms for different ultrasound machines, and sometimes different software programs. One of the questions we've had from the audience is about the variability between vendors. And I thought at this stage it'd be useful if I ask that. What do you think? You've co-authored chamber quantification recommendations, which are being updated. So a value is only as good as the ability to measure it and the person measuring it. So my question is, what about the variability between the different platforms?
I think when you think about variability, there are many types of variabilities, right? One is the platform. And when we talk about platform, we talk about Philips or GE or whatever. But then another one that is as important that is not talked as much is the software, because the software is being changed all the time. And thirdly is the operator. So there are many types of problems. I understand that, you know, the companies usually are pretty secretive of how this software or how they do this calculation and so on. I understand that, I mean, the Europeans and the Americans have really worked nicely in a task force and have shown that lately using the software that is, you know, the latest software, that the differences between the different companies is now negligible. Because before you would have to say, well, this cancer patient was imaged with this machine, I would have to continue to image with that machine. I don't think that's necessary anymore. And I think that they are very, very similar now. So I don't know, Paul, if you agree with that, but that seems to be the case now.
Yeah, I think that's true, and I think we're getting comfortable with the types of values we're getting, and I think there certainly has been a movement towards trying to standardize. Certainly in Europe a few years ago, there was a big push to try and standardize approaches and measurements across different platforms. So I think I guess it's not much different from, again, we talk about EF, but again, you know, there is probably some variability in how you measure EF between different machines and different processes, and you can get important to get a level of precision around your ranges. But the general ballpark, you know, the general figures you're looking at are probably going to be similar now across different areas to get that right. You know, the edge cases will be important to understand normal ranges for different cases, but you know, the big shift should be about standardized. But yeah, clearly, you know, systems which you can standardize across different vendors and different machines, you know, better in terms of reducing variability.
Now, this what Paul is talking about, I mean, does definitely not apply to 3D strain. Okay, because, you know, ideally, if you think about it, calculating 3D strain would potentially be the best measure of deformation that we could get, right? But there, if you use a Philips or a Tomtec machine or a GE machine, it's all over the place. So that there is still a huge, we actually wrote a paper about it. You take the same patient with these three machines, you get completely different numbers. So what we talked applies to 2D strain, but not to 3D strain. And another variability is the cut in which you do these measurements, right? So there are many, many potential places where you can create this variability.
Yeah, and I think that's a really good point, and I think it highlights that actually there's more to come from strain as well. I think, you know, the 3D strain as a standard, a gold standard, is really a really great thing to achieve. And it's always like, having said that, you know, the focus on 3D strain highlights actually the 2D strain now is actually pretty standard. You know, actually we're comfortable with 2D strain, and which is why I guess, you know, the push to use strain more has become so important. So, you know, where we were in terms of trying to standardize 2D strain 5 years ago or whatever, we're beyond that. 3D strain is very exciting as a way ahead. But actually 2D strain now is routine.
Yeah, and yeah, one of the issues about any form of echocardiography, whether it's 2D, but particularly 3D, is image quality. How much does image quality affect strain? The accuracy, does it really, is there evidence to show that that poorer quality images increase variability with manual contouring?
Well, 3D strain, as everything else that we do, is improving tremendously. So, you know, the newest 3D transducers, the quality of some of these pictures is approaching, not yet, but approaching TEE. I think that the quality is sort of getting to be okay. What is still a problem is the frame rate, right? Because even under the best of situations, we cannot achieve many times a frame rate of 60 or more that you would like for strain. But just give it some time, meaning if you think about that, people forget, okay, but echo is around 70 years since it was started in Sweden. And, real-time 3D echo is probably 12 years. And see what has happened, meaning it's unbelievable how quickly the technology is evolving. So give it a little bit of time and it will be solved.
What about strain measurement in 2D echo? How does image quality impact on the accuracy and variability for measuring in 2D strain?
Paul, or yes.
Roberto, carry on. Sorry.
It definitely has an impact, and many times already by eyeballing, where strain is going to work. But I am convinced that you can. We have probably much more obese patients than you have, and we still can acquire strain probably in over 70 to 80% of the patients. Sometimes you cannot do it in the 3 longitudinal views, and you can do it in 2. But in the vast majority of patients, you can get something that allows you. The software is really powerful, and it sort of catches, even if the data is not perfect.
Thank you. And do you want to add anything else, Paul?
Yeah, I was going to say, I think we're probably catching up on the obesity side here as well, actually, in terms of a number of patients, in terms of the patients I see. And I'd echo that, which is, I think you're right. I think we're very aware of image quality as very important in echo, and much like we wouldn't do, and that's also true for EF. Actually, getting accurate EF, so you need to make sure you've got endocardial border definition to do that. And it's probably not, the way we assess strain, it's probably not hugely different from being confident about your EF measurement. Actually, if you can get a reasonable EF measurement, you're going to be able to get a strain measurement as well. There shouldn't be anything more difficult about that. And with the hardware improvements in ultrasound, which we've been talking about, actually, and the improvement in the ultrasound probe quality that you're getting in terms of the image quality, it's increasingly become, when I talk to people who do other imaging modalities, very precise MR imaging modalities, and they spend a lot of their life doing that, their memory of echo is from 10 years ago when they used to do echoes. And if you show them the echoes of nowadays, the step up in quality of image in all sorts of sciences is so great that actually this question about quality is much less important than perhaps it was 10 years ago.
I would slightly counter you, Paul. I do cardiac MRI and as well once a week, and it's not as objective as it's purported to be in some by some people. There is a lot of variability there.
Yeah, I did the last time I did cardiac MRI was about 10 years ago. So in my practical experience, though we still use it in research.
And we're having some questions coming in, and I want to try and move on to more sort of practical issues about people who are probably not as familiar with strain and not using it in their practice. So, question for you, Paul. If someone didn't have a strain program or was interested in starting using strain, where would you recommend that they actually start using it first? Yeah,
so I think I guess you could be philosophical about this, which is the only way you can start on a journey is to take the first step. So, which is also true with strain. So I think the key thing is start getting the images, getting a system where you can get the numbers and start working with it. And you could argue that actually any patient you're wanting to assess left ventricular function with, you should get a strain measurement as well in these days. If you're particularly looking for one or two patients to start taking this forward, then you're guided by something like the kind of two scenarios. One is a scenario much like the patient I saw. So there's change of exercise tolerance. The EF appears normal. Are you 100% sure, or you're missing something? A strain is going to give you might give you reassurance about what's going on in terms of that. So that kind of situation is really good. The other situation is if you have the next step up from that, I guess, would be something like a coronary disease patient or a chest pain patient, which is now part of coming into guidelines in terms of how you might manage a lot more use of echo in resting cases for patients with coronary disease. You might see some regional variation as well if you're interested about whether there is a wall motion abnormality or there's some subtlety around it. So that's another step up. But probably the starting point would be try and get those global measurements and use those in patients with LV function. And then if it is abnormal and the EF is normal, think a bit deeper. It's no different from what we do if we get an ECG, which has a bit of abnormality in it. You don't stop there. You start about understanding whether there needs to be some further investigations. And similarly with that patient with a normal EF but an abnormal strain, then actually don't stop there, but think about what else you might need to do to explore that further and to understand why that might be the case.
Interesting. And you talked about a patient with coronary disease who has a regional wall motion abnormality and hopefully a regional, possibly a regional abnormal strain pattern. If I can turn over to you, Roberto, at the beginning you mentioned a case of amyloidosis. And in terms of amyloidosis, that has a classical abnormal strain pattern. And although we measure strain, there's also an element of pattern recognition. How useful do you find that sort of strain patterns, whether that is a bullseye plot or curved anatomical end mode in your clinical practice, rather than just the GLS number?
Yeah, that's a actually interesting question. So first, meaning at least in a busy lab in the United States, we do over 100 echoes a day. So very difficult to say, well, we're going to do GLS only in certain patients. It's much easier. We'll do it in everybody, because if you start picking and choosing, it doesn't really work. Now, to answer your question, there was a lot of literature saying that if you look at the bullseye of strain and you look at the cherry on top, in which strain is preserved in the apex and decreased, that is typical of amyloidosis. And then the reverse would be when you have Takotsubo, and there were all these patterns. I think that as many things that we do in medicine, it's totally exaggerated in a way. We actually were doing it in a study. We just recently took like the echoes of a month and looked at how many of these cherry on top patterns you would get. So in around I don't know, 1,000 echoes, we saw it in 30 patients. And then you say, oh, these all have amyloid, right? And then these patients were studied and you only found amyloid in a very small subset of those. So there are other situations in which you can get similar patterns. So in my opinion, it's a good way to alert you or to think about something. But like everything, there's a big hype, and then we get to find the real thing. And I think the cherry on top is a big hype, that when you study it very carefully, you'll see that there are other things that can give you a similar type of patterns. So I think it's interesting, these patterns. You look at it, it immediately hones you into a diagnosis, but don't consider that as done, because I think we are just all learning about it.
Thank you very much. And if I just turn to, we talked about the peak strain, the bullseye plot, and the cherry on top. Let's turn to a question from the audience. They particularly want to know about the clinical considerations and using peak systolic versus end systolic strain. What are your feelings about those? Which one should we use, or which is one better than the other?
For GLS or
for a regional strain, for segmental strain?
Okay, so that is another very interesting type of thing. And I think it now has been shown in amyloid and in many other things that, for example, if you look at LA strain, there you have the peak strain, which is also called the booster strain. And then you have, let's say, the atrial contraction strain. And all of these have, they have shown that all of these change in diseases and their proportions have an impact on survival and things like that. In amyloidosis, for example, your booster, your atrial contraction strain is reduced because the infiltration of amyloidosis prevents the atrium from contracting. So we will hear a lot about this. If you look into the literature, this is something that is all over the place. With GLS is the same. This is already published. If you look at this WASTE study, we have GLS done in 2,000 patients, and we average these curves in deciles of age. And you can see that just with aging, you can see that as you age, your left ventricular filling is much more dependent on the atrial contraction than when you are young, as your ventricle loses compliance. So it's very interesting because these changes occur not only in disease, but also with aging. We're going to hear a lot about this in the next couple of years. And so
another sort of practical question is, for you, Paul, now, any tips on performing strain and analyzing strain in patients with atrial fibrillation?
Yeah, so I think so it's a really good question. Lots of atrial fibrillation around, and it's a measurement. And I'm kind of taking quite a practical approach to the conversation today, which is that you treat atrial fibrillation much like you would doing measurements in any other types of measurements you're going to do in patients with atrial fibrillation. I.e., the usual approach in echo is you don't just do it on a single heartbeat. You do it over 3 or 4 heartbeats, and then look at what kind of levels. You're going to do that with your EF measurement. You're going to do that with your aortic, LV outflow tract velocity. Adopt the same approach with strain. Just get a few heartbeats and look at what your average levels are.
Interesting. We've got 2 questions.
Just a comment to what Paul said. Paul is very polite and has says what the guidelines, what the guidelines say. In reality, I have never ever seen somebody who measured ejection fraction in atrial fibrillation 5 or 10 times and averaged it, because there are not enough hours in the day to do that, right? So there is software that does it. I don't know how good, or people tend to choose a beat that they consider as average and so on. So atrial fibrillation is still a problem for which we have always a politically correct answer, but how much do we do? I don't know.
Yeah, it's a fair point. What is the difference sometimes between what you say you should do and what you actually do?
True. Guilty. So I think there are a couple of the attendees are asking about working on developing what you said previously, Roberto and Paul, but should we be measuring strain on all the patients? And should general cardiologists in routine clinical practice report strain on every patient? And I would say, if I can just partly answer that question, we've partly covered that, and it's a measure of systolic function. We have one measure of systolic function, which we're very familiar with, and it's that additive value of something that is, frankly, more reproducible, more sensitive than ejection fraction. And I suppose that the other thing is it important? Roberto, I think you alluded to that we take a huge number of measurements in an echocardiogram, from the start LV internal dimension upon the parietal long axis, lots of Doppler, tissue Doppler. There's only one measurement where, at least in the US, it is reimbursed as its own CPT code. Then presumably one would infer, or a cardiologist would infer, at least one who doesn't practice in the US, that that it's deemed to be significantly important. The additional time / resources required to measure that is so important that this one measurement deems a specific payment. So and it is in the guidelines there as well. And if I can go back can move on from that point and develop the guidelines, we talked about, we've hinted at the chest pain, recent AHA-ACC chest pain guidelines that came out at the end of last year. What role does strain have in aortic stenosis, mitral, and other types of valvular heart disease? If I can just ask that one to Roberto.
Can I make a comment of the first part of what you talked about? Doctors communicate in terms of ejection fraction, right? Everybody, an endocrinologist, a dermatologist, even an orthopedic doctor knows about ejection fraction. And most of them got an idea that it's over 55 is normal, mostly. Nobody knows about strain. We still have to do a major educational thing because our colleagues don't have a clue. I also wanted to make a comment about the money because the money is, we get a certain payment in the United States for doing an echo, but the echo should be done according to the guidelines and should have a biplane ejection fraction measure. That's part of it, okay? Then they came up with this very small additional payment for doing strain. I think the idea is that you need to buy more money to get the software. And the same thing they did for 3D echo. I have been doing 3D echo for many, many years, and we bought all this equipment. We never got paid, and now we get a very small amount. So I want to, and I totally get what Paul said, which is true, that in the United States, you get this small additional payment, and that acts like a superb motivator for everybody to do it. And that's why you would say, well, let's do it on everybody because, and I think it has benefits. Regarding now the use of strain in valvular heart disease, there are a lot of papers that show the value in AI, the value in AS, the value in mitral regurgitation. In the meantime, at least in my lab and so on, that's mostly research. I don't think that has still penetrated, like Paul said, a practical applicability. I don't see anybody making any decisions on what you're going to do with an AS patient based on strain yet. I don't know what your experience is, Paul, but that is sort of.
Yeah, I think that's true. There are kind of these areas where we're definitely learning more about strain and its uses. And I think valve disease is one of those areas. I think one of the other areas we've been doing research around is some of the younger patients with heart disease, or even things like hypertension or other changes. And you start to see these changes in strain well before you get EF changes, and they're there. And what we need to understand is what's their relevance, how do you manage that for those particular patients. But there are other situations which we've been working with, and I guess one we haven't talked about today, but it's one of those areas, cardio-oncology. Actually, they're actually you're in a situation where actually the routine should really be now, because we've been looking at it for a while. Is if you ask the questions, is left ventricular function okay? Then you say yes, EF is normal and the myocardial strain is normal, therefore it's okay. You don't say the EF is normal and therefore it's okay. You say both those metrics are normal and therefore we're confident. If one of those is abnormal, if EF is normal and the myocardial strain isn't abnormal, then that's a different type of patient. There's something else going on. And we've got it's kind of thinking that for some of these conditions where you're looking at early risks of cardiomyopathy or early or evidence that perhaps they've got some coronary disease or something, actually you're not confident that the cardiac function is normal until you know the EF is normal and the strain is normal. And that's kind of a way of thinking.
Sure. If I just go to another question from the audience, a good question. How load dependent is strain? And should we avoid using it in patients who are hypertensive at the time of the study? And I would actually add, or hypotensive at the time. Can I ask that to Roberto?
I think it's very low dependent. We actually did some studies we had the opportunity to measure strain in some of these parabolic flights. in which you put somebody in there a couple of, like a minute and a half that you go to zero gravity. Or we also did some studies of putting patients in tilt tests, and it is very, very preload dependent. So it's still being, we try to advertise, that this is less load dependent. I am not sure that it is.
I could perhaps talk to the hypertensive situation as well, which is, again, actually, we've done quite a lot of studies in patients who are hypertensive, and you can see a range of strain values in those groups as well, with menial effects. Actually, and if you look at those who potentially have normal EF but abnormal strain, that has knock-on effects in terms of their other characteristics of physiological effects within the hypertension. So they appear to have changes in their exercise response and other things. So the changes in strain are meaningful in that group as well.
So that's interesting, because conventionally, when in terms of hypertension, we've had this arbitrary, well, not arbitrary, we define hypertension with and without end organ damage, renal, ocular, or cardiac, and others. So I suppose, and conventionally for cardiac end organ damage from hypertension in the heart, we've been thinking about LVH primarily. So should we actually be thinking about moving towards incorporating strain in the hypertensive patients, because we are seeing, do changes in strain precede changes in hypertrophy?
Yeah, I mean, this one of a particularly exciting area, and something we have been looking at in terms, as you say, end organ. Our cutoffs for understanding whether there's end organ damage, particularly in maybe middle age or younger hypertension, is you have left ventricular hypertrophy, but you have to have quite a degree of damage done to get to that stage. And clearly, you do get these changes in strain that precede these, which we reported on from a research perspective. And I think that's really a question. I don't think we have the answer yet to say we can put this in clinical practice, but that's certainly one of the reasons why actually more knowledge and experience of strain is going to be really valuable, because these kind of metrics are going to gain value in terms of how they're used in different clinical situations over the next few years.
And if I can say, another area we have, because I'm seeing we're running out of time, but one of the things that we have not talked about where I think strain is very helpful is in the assessment of the right ventricle. Because we in echo use TAPSE and the S-wave, and those are really pretty bad or measures of just looking at the longitudinal in one single segment, and they get confounded by the presence of TR and so on. Right ventricular free wall strain is a very, very useful, in my opinion, way to assess the deformation and function of the right ventricle. And that's something we did not talk, but people who might be listening might be thinking about that. It's a very practically easy and useful thing to do.
That's very helpful. So we're coming towards the end of the hour, and I've got a question on, can someone, what about, is there a useful reference for people who are new to strain? And I would start off by mentioning the ASE recent textbook. I think one of the co-authors or the editors is you, Roberto. Are there, so one of the, a good reference paper that I found was a review written by Potter and Marwick in JACC Cardiovascular Imaging, I think 2018. It was quite a nice short and readable summary of strain and also diseases that it was used. And then if I can, if I can end with a topical question. We're now 2 years into COVID-19, and we've talked about strain in multiple diseases, but in every clinical meeting, in every specialty, cardiology and all others, there should be a question on COVID-19. If I can ask you, Roberto, because I think you were involved with Waze COVID. How has strain or is strain useful in COVID-19, and what's been shown the effects of strain?
Yeah, that's a good. I mean, there are two. I would summarize it into two sentences. I mean, the first ones, the people in Wuhan in China were the first ones to show that right ventricular strain was affected in COVID-19 in the first way. We had the opportunity to do a study with Ultromics. Ultromics was very helpful, and we actually showed that the same thing, that right ventricular strain was very affected in these patients, and it varied according to the area of the world. But the other thing we really found in that paper is that not only the left strain was affected, but also not only the right ventricular strain, but also the left strain was affected. And that was not shown before because it was measured by humans with a lot of variability. As soon as strain was measured with artificial intelligence, it became significant because you decrease the variability. So I learned from that artificial intelligence to do studies and to measure echoes is super, super helpful and can really lead you to obtain more information. So that is sort of what I learned from that.
Well, thank you very much. And I think we're coming towards the end of the hour. We've ended with a topical question and area. I'd like to firstly thank Roberto and Paul, both of you, for attending and presenting, talking about this fireside chat. And I'd like to also thank all of the audience for attending, and also all those who asked questions. I'd like to apologize for those whose questions were unable to answer. What I will say is that this session was recorded and it will be shared with all attendees. If we weren't able to answer all your questions, we'll try and include a document to all attendees with a response to those questions. And finally, I'd like to end by saying that there will be a further webinar in this series. The next one will be in March on chest pain. And with that, I wish to bid everyone farewell, and enjoy and have the rest of your day and have a productive day.
Thank you very much. Thanks, Rez. Thanks, Roberto.